Welcome, everyone. We're thrilled that you've joined us today, the Hollingshead Barrett Eye Center Vision Correction webinar. Hollingshead Barrett Eye Center is proud to serve the Treasure Valley and has served the Treasure Valley for over 30 years, offering the latest, greatest technology in vision correction. So today, pleased that Dr. Barrett will be doing our webinar and guiding us through the conversation of many of the common vision correction procedures, including LASIK, PRK, ICLs, refractive lens exchange, and advanced cataract surgery. Dr. Barrett is a fellowship trained ophthalmologist specializing in corneal and refractive surgery. And as I mentioned earlier, we are pleased to have him with us today. In addition, we're going to answer many of your questions that you may have regarding vision correction. There is a function in today's webinar, and we'll be taking those questions through the Q&A section. So as you have questions today, please feel free to type those in. And at the end of the presentation, we'll answer as many of those as we possibly can. Once we get to the end of the presentation, we'll give you information on how you can learn even more than Dr. Barrett's going to provide you today about additional vision correction procedures that might be right for you and your vision. So with that said, I'd like to introduce Dr. Ryan Barrett of the Hollingshead Barrett Eye Center. Dr. Barrett, thank you very much for joining us, and I'd like to turn it over to you now.
Hello, so as Bill had mentioned, I'm Dr. Barrett, and really pleased to be joining you today to discuss different ways to facilitate better vision with decreasing for glasses or contacts. Like Bill had mentioned, we're here in Boise. We've been here for over 30 years, really focused on vision correction throughout that entire time through a variety of procedures. As technology has advanced throughout the years, we've really tried to maintain our position really at the forefront of those advancements with LASIK and PRK, implantable contact lenses. In addition to providing normal other kind of comprehensive eye services like cataract surgery, glaucoma surgery, cornea transplantation. And we do all of our care, both clinical and surgical, here in our eye center. We have a clinic attached to a surgery center, and all of our surgeries are done in that surgery center, fully accredited with an anesthesia provider to ensure comfort. And this is our team. We have three surgeons there on the left, myself, Dr. Wolf, and Dr. Messenger. And then on the right of your screen, we have our three optometrists who are all phenomenal. And when patients come in for an evaluation with us, they'll meet with any one of those six providers, and that will kind of guide the treatment from there in terms of what may be most beneficial. As Bill had mentioned, I'm fellowship trained in anterior segment surgery. Did the bulk of my training first medical school at University of Washington, and then my residency at Baylor in Texas, and then fellowship in Minnesota. And my fellowship was really focused on refractive surgical care of the front of the eye, including LASIK, implantable contact lenses, as well as corneal transplantation and advanced cataract surgery techniques for complex cataract surgeries. And I've been here at Hollingshead Barrett Eye Center since 2016 for 9 years now. I'd like to go over several different types of procedures that can be done to help improve quality of vision and decreasing for glasses. And we're going to start first with some external procedures that enable the ongoing use of the natural lens of the eye, and then discuss some other procedures that can be used to replace the natural lens of the eye with an artificial lens. As we talk about vision correction, there is no one perfect procedure for everybody. And it's very important that any plan for surgery correction, for vision correction, is customized and really specific to each individual. Just like one person's pair of glasses wouldn't be ideal for somebody else, really the same is true with surgery. We really want a customized plan. In general, those who are on the younger age spectrum, starting around age 18, we'd be looking more at a laser vision correction procedure like LASIK or PRK. For stronger correction or for different shaped corneas, maybe we'd be talking about an implantable contact lens. As we get closer to needing some near vision correction in addition to distance correction, we may then move into more of a conversation about what's called refractive lens exchange. And then I'm going to go over all of these in greater detail, but this is kind of the general layout, the order that we'll be discussing different procedures today. And again, if you have any questions as we go along, please utilize that function that Bill mentioned in the beginning. There's a question tab on your screen. You can click that, type in your question. I will be going over some general questions we expect, but if you have a specific question, I'd love to help with that too. And you can ask that question through the question tab. Just for some basic normal anatomy, you see here a picture of what the natural eye looks like. I want you to pay attention to a couple of aspects here. If you look at the very front of that image, there's a part labeled cornea. That's the clear front part of the eye. If someone were to put a contact lens on their eye, it sits on the cornea. And some of the vision correction modalities we have will change the shape of that cornea, and that's how we can improve vision. Behind the cornea, there's that colored part of the eye called the iris. The iris is kind of a divider as we look at the front of the eye, what we can see without dilation. Behind the iris is the natural lens of the eye. There's a little gap between the lens of the eye and the colored part of the eye. And in that space, that's where we can sometimes put another lens. If we need to, we'll talk more about that, but shaped like an implantable contact lens. And then that lens of the eye, when we're born, is crystal clear, like in this image. And with time, it can cloud, and that's what we call a cataract. And cataract surgery would involve removing that natural lens and putting a replacement lens in it to take the spot of the natural lens. We can do that procedure early before there's a real visually significant cataract and put a new lens in with someone's customized prescription, and that would be a refractive lens exchange. But this is the natural anatomy of the eye. Ideally, this whole system is designed so that as light passes through the cornea, through the lens, it will focus in one crisp, distinct spot in the back of the eye on the retina. And you can see that outlined here diagrammed with this A that reaches one single point in the back of the eye. Sometimes the eye is not the ideal shape. The cornea, the front of the eye that we talked about, ideally would be round like a ball. If it's not, if it's shaped a little bit more like an egg, instead of getting one distinct point on the retina where it will focus, it will actually bend the light and you get multiple focus points. And that can really blur the image. And so you can see that here on this diagram, we've got these different A's here. If the eye is too short, maybe it will focus the light behind the retina. That'd be for a far-sighted eye. Or if the eye is too long, it may shape or focus the A or the image in front of the retina. And then we call that being nearsighted. And that's what glasses and contacts are designed to do. They're designed to shift that focus point to put the image right back on the retina. And then if we want to reduce the need for contacts or glasses, we can then utilize surgery to get the image that we're looking at to be right on the retina without needing glasses or contacts. And that's the goal of all the procedures we're going to talk about today. The first procedure I'd like to discuss is probably the most well-known of all refractive eye surgeries. Refractive meaning we're trying to reduce the need for glasses. What we're doing with LASIK is we're going to use two different lasers. We have, this is totally blade-free procedure nowadays. So what we do is we have one laser that will create a little flap in the cornea, which is then reflected back like you see in that middle image. We then can use a second laser that will remove tissue and reshape the cornea so it has a perfect shape so that the image that we're looking at will focus right onto the retina. We then can hinge the flap back over the area that's been treated, and it can cover the treatment area. That covering of the treatment zone really facilitates a very rapid healing, very rapid vision recovery, very minimal discomfort throughout the healing process. This procedure is really great for people who are nearsighted, people who have a mild to moderate amount of astigmatism, and for low degrees of farsightedness. It is not as great for those who have a extreme amount of astigmatism or an extreme prescription. We can kind of reach the limits of what LASIK can do, but a very effective, very rapid recovery, very comfortable procedure. Similar to LASIK, but slightly different, is another laser vision correction surgery called PRK. PRK is very similar to LASIK, where we're going to use a laser to reshape the cornea with the goal that we're going to have the image we're looking at focus right in the center of the retina. In fact, we use the same exact laser that is used in the second step of LASIK. The difference between PRK and LASIK is that with PRK, there is no flap. Rather than using the first laser to create a flap in the first step of LASIK, with PRK, we just gently brush off the surface layer of the cornea. We use the same exact second laser to do the same exact reshaping of the cornea. And then we let the eye heal. And we put a contact lens on top of it to help facilitate some more comfort and help it heal faster. The primary difference between PRK and LASIK is because there is no flap with PRK, the recovery is not quite as comfortable. With this one, I do tell patients expect it to be fairly uncomfortable for about 3 or 4 days. It'll be burning, it'll be gritty, but then that will pass. Usually by day 4, things are feeling much better, and then the recovery is very smooth after that. Additionally, because we're having to rely on the cornea to heal itself, the vision recovery takes longer to come in. And so whereas LASIK, I expect to be very clear even the next day, with PRK it can take a couple of weeks or even a month or two for the vision to fully recover and stabilize. The benefit of PRK would be if someone has a strong prescription or a thin cornea where we don't want to affect as much of the cornea with our treatment. PRK enables us to be more superficial with our treatment and affect less cornea. Additionally, there's no flap to worry about in terms of future activity. So if someone is very active in terms of, for example, people who do martial arts or kickboxing, some police officers will choose PRK just in the chance that they want to avoid the chance of anything disrupting the flap in the future. But another equally safe procedure like LASIK, just a different recovery. And that is kind of the laser vision correction options. Now, ICLs are different. We're moving from a surface procedure with laser vision correction to now we're moving to procedures inside the eye that can improve the vision. And so that the first of those is what's called an implantable contact lens or an implantable Collamer lens. What this is an additive procedure that we can do to help add someone's natural contact lens prescription into the eye with a kind of a permanent contact lens. And the benefit is that unlike LASIK, we are not needing to remove any tissue. And so this enables us to treat a much larger range of prescriptions. We don't need to worry about the normal thresholds for tissue removal because we can treat even very, very strong prescriptions. Additionally, technically, this is a reversible procedure because we're not removing any tissue. We're just simply putting a new lens into the eye. That lens, if there were any issues, could be removed. And so, for example, if someone were having glare or halos, which we would not expect, that's very uncommon with this, but if they were, well, we could take that lens out and they would return to their pre-surgical correction. This has a different age range that implantable contact lenses are approved for. LASIK is approved for anyone age 18 and older who has a stable prescription for at least a year. ICLs in the US are approved for age 21 to 45. And so a more narrow age range, but a very good treatment option. So again, let me actually go back to that. So as we are moving from the front to internal in the eye, on the front of the eye, we can resurface a cornea to achieve a prescription change with LASIK or PRK. As we move into the eye, that gap between the color part of the eye and the natural lens of the eye, we can insert another lens into that gap. That's the ICL. And then our last option is called a refractive lens exchange. We often abbreviate that RLE. With this lens, we're again going to leave the cornea alone. So we're not going to reshape the cornea. We're not going to add a new lens in addition to the lens. We're actually going to remove the natural lens of the eye and put a new lens in to replace it. And we would put in a lens that has the appropriate prescription in that lens to help achieve spectacle independence in daily life. And so just replacing the natural lens of the eye with a new lens that's more appropriately shaped to give good vision without needing glasses. And so this is a very beneficial procedure if someone already is what's called presbyopic, meaning they already are finding that they are needing reading glasses. Why do we lose our near vision? Why do we start to need reading glasses? That's a very natural process. In our eye, we talked about how behind the colored part of the eye, there's a lens. And you can see that in this top image here. Okay, if you look, there's the top curved area of the cornea, the colored part of the eye called the iris. You can see in this image, there's a little bit of a clear lens there. When we're born, that's clear, it's very flexible. It can change its shape to focus from distance to near. Around age 45, that lens naturally undergoes a process where it stiffens and it loses ability to change its shape. And that's why we find we no longer can start to, our arms need to become longer and longer to see close up because a lens can no longer flex to bring vision into focus. Once that lens becomes stiffer and loses the ability to focus up close, we lose that near vision and we start to need bifocals or reading glasses or glasses for the computer. The options we've discussed up until this point will not affect, it will not help the need for up close um, uh, reading vision, meaning it's great for distance vision. And if someone doesn't need reading glasses, they should still not need reading glasses after LASIK or an ICL. But after age 45, we'd expect everyone to start getting to the point where they will need reading glasses. So if they already need reading glasses, we may say, well, is there an option to help not just the distance vision, but also the up close vision? That's where this becomes a wonderful treatment, where we can remove that natural lens of the eye that is becoming stiffer and put a new lens in that has both far and up close prescription built into it. This is essentially doing cataract surgery before there's a medical cataract present. And so let me go back to this. And I do want to pause for just a moment as we discuss this because we're going to start talking about some different lenses that can be used to replace the natural lens of the eye. It's important to understand every lens has some compromises. As we talk about all these new lenses, none of them are as good as the lens that we're born with. And so any lens technology that we discuss as we talk about replacing the natural lens of the eye will have benefits and then it will have some compromises that we just have to live with. And so that's why we don't jump into doing refractive lens exchange for younger patients who are not or have not already lost their near vision. We want to preserve that natural lens as long as it's working well. When it starts to become dysfunctional, no longer help with the near vision, that's when we want to replace it. And then we kind of pick which lens would be, again, best for helping achieve that goal. Cataract surgery, it would be essentially, again, if we wait long enough, that natural lens of the eye, not only will it lose ability to focus up close, will actually become clouded, and that will make the vision blurry. It can make it so there's a lot of glare. It can make it so that even with glasses, we cannot see well. That's when we talk about doing cataract surgery, which would be a medical procedure, that one that we would typically expect to go through insurance. We remove that cataract and then we put a new lens in to replace it. And again, just like refractive lens exchange, I'm going to go over several different lens options that we can use to replace the cataract. It'd be the same bevy of lenses that would work for refractive lens exchange. The same lenses would be a good option to replace the cataract. Again, it's the same surgery, just either before or after cataract development. So common questions, and hopefully we've answered some of these as we go, but what's the difference between PRK or LASIK, ICLs, and refractive lens exchange? Again, PRK, LASIK, and ICLs, these are wonderful procedures for people who still have a preserved ability to focus up close. In general, they tend to be younger, and we're simply changing their vision to match what glasses would give them. With PRK and LASIK, those are laser corrective surgeries where we're going to use a laser to reshape the surface of the eye. With LASIK, we have a flap. With PRK, we do not. With an ICL, we're adding a new lens into the eye to match the prescription. PRK and LASIK are done in a laser suite where we have, it's not an operating room, but rather a laser procedure suite. ICLs we do in the operating room with some anesthesia present to help with comfort. Refractive lens exchange is better for those who have lost ability to focus up close. And in addition to wanting to see better at distance without glasses, they also want to bring in some ability to see up close at the same time without glasses. Also done in the operating room with anesthesia. Can these procedures treat astigmatism? Yes, they can. All of them can within limits. We can treat up to about 4 diopters of astigmatism with LASIK, a little bit less with PRK, and then we can treat about 4.5 diopters of astigmatism as well with ICLs or refractive lens exchange. So we can treat up a fairly regular astigmatism up to a point. And if we are unable to completely treat, say someone has more astigmatism than that, sometimes it can be very helpful to knock that down to a very manageable level. So even if we cannot fully treat even extreme levels of astigmatism, if we can sometimes cut that down by about 90%, it can make glasses work far better for those individuals, but that's quite uncommon. Can I have vision correction procedures if I've had LASIK or PRK in the past? Yes. Again, there are some caveats with this. It kind of depends on how much laser vision correction someone had in the past. If someone had a very strong prescription that was treated, we may not want to do another laser procedure on the cornea. But if someone has a very healthy appearing cornea, we could do PRK, even if they've already had LASIK. We would not typically do LASIK again, just because we don't want to create a second flap. ICLs could be done, though that's very unusual to do that after LASIK. Refractive lens exchange, that's very commonly done actually after LASIK because oftentimes some may have had LASIK in their 20s or 30s. It's been wonderful for 10 to 20, 30, 25 years. And now they're in their mid 40s or early 50s and finding, man, I'm doing okay at distance, or maybe there's a little need for glasses at distance, but I'm really struggling with this loss of my up close vision. Is there a way to get out of glasses for far and near again, like I had in my 30s and 20s? And the answer for those patients would be a refractive lens exchange. How long do these procedures take? PRK and LASIK are both about 10 minutes for both eyes, 10 to 15 minutes for both eyes. And again, that's done in our laser vision correction suite. The ICL surgeries, we treat that as two completely separate surgeries. So we do them both on the same day, but we do that in our operating room with anesthesia. I would expect to be here for a couple of hours for that, about 2 hours typically from when you check in to when you check out. The actual procedure is not that long. The surgery time is about 10 minutes per eye, 10, 15 minutes per eye for ICLs, but you're here for a longer period of time for that. And the same is true for refractive lens exchange. Typically for a refractive lens exchange, for those, we actually do one eye per day. We don't do them both on the same day, but I typically would do those both in the same week. So we might do, for example, your right eye on a Tuesday and your left eye on a Thursday. And that gets both eyes healing very quickly together. So you can go through that healing process all at once and works very well. Will I feel any pain during the procedure? You should not, no. Each experience is a little bit different with these different procedures. With the laser vision correction procedures like LASIK or PRK, typically we would give you a little bit of Valium prior to the procedure so that it takes the edge off the nerves. We'll use topical numbing drops for the eye so the eye is very comfortable. And typically you will feel a little bit of pressure, especially with LASIK, the very first part of that procedure where we use the first laser to create that little flap. I would expect patients to feel some pressure for about 10 seconds for that. And then there should be no pain, no discomfort. If that were something that someone was experiencing, I certainly would want them to let me know. Um, PRK, you don't have that pressure part because we don't need to create the flap. That should be very comfortable. With both ICLs and with refractive lens exchange, there should be zero pain with those because again, we do those in the operating room with an anesthesia provider. So you'd be mildly sedated for those and completely comfortable. Any limitations on activities after these procedures? All of them have some limitations for the first couple days, a week or two after the procedure. For all of the procedures we ask that you not go into water like swimming pools, hot tubs, saunas, lakes, rivers, streams for about 1 to 2 weeks afterwards, just to minimize that risk of infection. For LASIK and PRK, we ask that you avoid strenuous activities for about a week, and after an ICL placement or refractive lens exchange, we ask that you avoid strenuous activities where you're lifting more than 20 or 30 pounds for 2 weeks after the procedure. And then with all of the procedures, you would have some eye drops you would use for either 1 to 4 weeks after the procedure, depending on which procedure you had done. Will I still need cataract surgery in the future if I have a refractive lens exchange? And the answer to this is no. And that's really one of the beautiful aspects of an RLE. We know that cataract surgery is the most commonly done surgery in America. All of us, if we live long enough, should expect to need cataract surgery in our future. If someone has a refractive lens exchange, they've essentially done that preemptively. They will never need to have cataract surgery down the road because that's already been addressed at the time of the refractive lens exchange. Are these procedures permanent, or do I need to have them done multiple times? The expectation with all of these is that these would be a permanent in the sense that we would not need to repeat these type of procedures. And I tell people, think of this like we are putting your glasses prescription or contact lens prescription on your eye permanently. So with LASIK and PRK, that we're going to essentially be taking that prescription and reshaping your eye to match what your glasses prescription or contact lens prescription is today. Just like you may not expect if you were to go to your eye doctor today and get a pair of glasses that's just the most perfect prescription you've ever had, that may not be the most perfect prescription 20 years from now. It would be pretty common to expect a little bit of drift over time of your prescription. The same is true after LASIK or PRK. We're not changing the fact that your eye may have a little bit of change over time, but thankfully, for most of us, those changes are pretty well stable after age 18 to 20. And so we don't expect much change. So, for example, I had LASIK myself about 19 years ago. I love it. And I still find I see 20/20 at distance and near, no glasses. And I expect that from my patients too, that there may be some mild change over time, but that should be pretty minimal. With a refractive lens exchange, especially, that stability should be rock solid. I expect very little change over time after a refractive lens exchange. Are there side effects from the different procedures? Yes, every surgical procedure always has a potential for risk or side effects. Thankfully, these risks and side effects are pretty minimal. Most patients find that the side effects are fairly temporary, and so those should be pretty minimal. Side effects I would expect early on after LASIK and PRK would be increased dryness. Most patients will find that for the first weeks to months after surgery, there is an increase in how dry their eyes feel. And so I would want patients using artificial tears. Large studies have shown that dry eye symptoms actually are improved 9 months after surgery compared to before LASIK surgery. And so that would actually be something that I would expect to be more temporary. A risk of glare, like starbursting with lights at nighttime. I expect again, with all of these procedures, everyone will see that at least for a week or two. Again, most patients will find that will fade over time and really diminish over time. Those are the main side effects I would expect. And again, I would expect those to really diminish and improve tremendously over time. And actually, oftentimes people find that the starbursting they have is far less than they had prior to surgery because now their astigmatism has been corrected or they have less prescription. How long is recovery time? Again, for the laser vision correction procedures, we have LASIK is about a week. For PRK, it's longer to heal, usually about a week before things are feeling pretty good, but up to 3 months for the vision to be fully stable. And that is kind of peak improvement and where you no longer gain those fluctuations throughout the day. With an ICL procedure, it's usually about a week for the vision to stabilize and recover. And same thing for refractive lens exchange, about a week for that as well. Will I be able to see both near and distance vision after the procedure? A lot of this depends on if you are able to see with glasses near and distance before the procedure. If someone has that full range of vision with just distance glasses, then yes, I would expect after LASIK or PRK to still be able to see that full range of vision after LASIK or PRK. And same is true with an ICL. If someone already needs reading glasses before LASIK, or PRK or an ICL, those procedures are really only correcting the distance vision. And so I would expect you to be able to get freedom from the far away glasses But if you needed reading glasses before those procedures, then you would still need to use reading glasses after those procedures. A refractive lens exchange is different. We have lenses we can implant that have far and near built into them, and that would be a way to get distance and near vision after a refractive lens exchange. Now, I did mention earlier that there are compromises with every lens out there. The lenses that help us see far and near are called trifocal lenses or extended depth of focus lenses. And while they work very well in that regard, they're not perfect. Usually I tell people these are like 90% lenses, meaning they're designed to get us out of glasses for about 90% of what we do. And again, I'm speaking specifically to the lenses used to replace the natural lens of the eye, so refractive lens exchange or cataract surgery with an advanced technology lens. And so with one of these advanced technology lenses, I would expect 90% of what we do, we can do without glasses on for very visually demanding activities. Maybe someone who likes to tie flies, or does a lot of needlepoint cross stitch, things that are really visually demanding for the up close work. That's probably beyond what these advanced technology lenses can do. Probably would want to wear a pair of reading glasses for those activities. Maybe for driving at nighttime, that can be a very visually demanding activity. I'll have some patients keep a pair of glasses in the car for driving at nighttime to use if needed. But in general, the goal is to get people out of glasses for most activities around the house, watching TV, just living life. We should be able to do those things without glasses on, mountain biking, skiing. How much do these procedures cost? All of the procedures we've discussed today are considered elective, and so they are not typically medically insurance covered procedures. Now, there are some insurance plans in the Valley that are picking up a part of these, and so it'd be something to have to talk with my coordinators about. I actually don't have the details on in different insurance plans, but I do not know that there are some plans that do cover a portion of LASIK and PRK. But in general, there are a couple $1,000s per eye. The procedures that are done in the operating room, for example, the ICL and the refractive lens exchange, those are more expensive because they have the additional fees for the anesthesia provider, for the nursing staff, for everything else that is done that happens in the operating room. And so those are a little bit more expensive. Are any of these procedures covered by insurance? Just like I just mentioned, some insurance programs in the Valley or some employers are picking up a part now of LASIK or PRK. And that's something we'd have to look at on a plan by plan basis with you. How do I know if I'm a candidate? This is a great question because not everybody is a candidate. Now, there is, with so many different options available, typically we have an option for almost everybody that should work well. But even with all these different options, nothing's perfect, and we don't have an option for every individual. And it's important to remember that these are elective procedures. So we want to be careful. We don't want to kind of push the envelope and treat patients who we don't think would be safe to treat. And so we offer free screenings to anyone that's curious or interested. If someone would like to come in for a LASIK screening, they can call our office, and we'll make sure that the phone numbers appear on the screen in a moment and coordinate to come in for a screening exam where we would check the vision. We would take some measurements and pictures of the cornea and look at the shape and the thickness of the cornea. And you can enroll or sign up for one of those free screening visits either by calling my office, or we have an online scheduling portal now as well, that we can work with as well to set that up online. Why should I choose Hollingshead Barrett Eye Center? Well, I'm not biased at all here, no, but we really care. I would say that we're here part of the community. We live here. I see my patients all the time out on the trails, at Costco, at sporting events, and community events. So we really have a vested interest in making sure that our patients have a very good outcome. We want you seeing well. Like I mentioned, I've had LASIK myself. I know how life-changing it can be to see clearly without needing to put glasses on in the morning, to just wake up and see the clock, to be able to go skiing and not worry if my goggles are fogging up. And so we have a high, strong interest in both safe outcomes and excellent vision outcomes. We have the latest technology that we use for diagnostics, that we use for the treatments with our lasers. And we take time to really make sure that we're taking good care of you. We also have a very good relationship with many of the doctors, and I'd say almost all of the doctors in the valley. And we coordinate a lot with people's own eye doctors to be able to work with them preoperatively and postoperatively and collaborate on that care so we can have that continuity there, um, if that's something that patients desire as well. And that's, I think, a real benefit here as well. So if you have additional questions or there are different options, you can either give us a call at that phone number there, 208-336-8700, or you can go on to the website there, homes@barretteyecenter.com, and you can sign up for either virtual screening, which has less information because we can't measure the cornea, obviously, virtually, or come in for a free screening in our office where we can measure your cornea, take a look at that. And just be aware, again, the question, why should you trust us? We are very careful. In full disclosure, about a third of patients that we assess, we find their cornea may have findings that we wouldn't feel safe doing laser vision correction. So just know there is a reason for the screening. We do take it seriously. We want to be careful. We want you doing well. I appreciate all of your time. And Bill, thanks for helping set this up.
Thank you so much. Excellent, excellent presentation. Dr. Barrett, we've had a couple of questions come in. I don't know if you can take a few more minutes with us
Absolutely.
to answer these. But we did have a question from the audience about have these procedures changed over the last few years, particularly since COVID?
Because there are about five different procedures we talked about here, let me kind of go through each of those. So LASIK and PRK, no significant changes specifically since COVID. I will say though, there have been changes separate from COVID. We have some advancements in technology in terms of some of the diagnostic equipment that we're able to use to not only assess safety of the procedure, but even higher definition mapping of the cornea. And we can now do some what are called topography guided treatments that may have a little bit less chance for glare and halo. That risk was already very low to begin with, but maybe even lower now. A slightly higher chance of 2015 or better vision as opposed to just 2020. So those are some progressive advancements we've seen and the ability to deliver the laser treatment in a slightly different manner. With ICLs, I think one of the greatest advancements we've had have been in this realm. We've had ICLs for decades. There's been and we used to have to do a laser procedure to create some additional openings in the iris to make it safe to put the ICL in. There's been a newer generation of the ICL called the EVO ICL that's been released and approved, and it was about 5 years ago that hit the US and has been really phenomenal. It makes a much safer procedure, a much simpler procedure. We no longer need to do a laser procedure a couple of weeks ahead of time to create additional permanent holes in the iris. We're able to avoid that, and really has improved the safety profile of the ICL surgery. And I've loved that lens. It's been phenomenal. Probably the most advancements have come in the refractive lens category or the cataract surgery category with advanced technology lenses. Dream, the holy grail in surgery for this area has been if we can make a lens that works as well as a natural human eye lens with this wide range of vision, the great depth of focus that we naturally enjoy from birth, with the least risk of halos and glare. And while we're not there yet, certainly the range of vision we've been able to see with the newest generation lenses, even the last 2 years, is phenomenal. Much greater range of vision, much lower glare and halo profile. Additionally, there's now even an adjustable lens that is a lens made of a material we can actually
Wow.
put in a lens that's already kind of close to what someone's desired prescription would be for their natural to have good vision at distance or near. But it's made of a material that we can actually fine tune and adjust the prescription of that artificial lens inside the eye for the first 2 or 3 months after the cataract surgery or refractive lens exchange surgery. And so we do the lens exchange surgery, we take out the natural lens of the eye, we can put this new lens in and let the eye heal. And then about 3 weeks after the surgery, we can come back and remeasure the vision and see, is there any leftover prescription? Is there anything that glass would make the vision even sharper at distance than what we got with this lens to begin with? And if so, we can then take that prescription and rather than doing a glasses prescription, we can put it into this computer program it will program a light that will shine a light on the lens, reprogram the prescription of the lens inside the eye to match precisely what the glasses had. And it's incredible. We're seeing 99% plus patients have 20/20 vision with that lens. The drawback is it's not a far and up close lens. So it's not an extended depth of focus lens. It's really a distance lens. And we can try and expand that focus by doing a minor offset between the two eyes. But that's really incredible technology and really exciting to see. Has very little glare and halo. The accuracy is off the charts. So less change on the laser vision correction front, as except for the diagnostics and some of the topography guided treatments. A lot of change in the type of lenses we have that we can implant in the eye with either an ICL or an RLE or a cataract surgery with an advanced technology lens.
Dr. Barrett, there was a question that came in during your discussion there about the LAL lens or the light adjustable lens. I assume the LAL and the light adjustable lens are the same. And the question from the audience was, do you feel you're getting good results with that technology?
Yeah, thank you. And I apologize that I do find that I sometimes start speaking in acronyms. So LAL stands for light adjustable lens. Those are one and the same. The outcomes with the light adjustable lens or the LAL have been in our hands phenomenal. Again, there is no perfect lens out there, and I would never want to portray that. But this has been a very accurate lens, and by far the most accurate in terms of being able to confidently say, okay, I feel very confident we can get you as clear as glasses ever could, without needing to wear glasses at distance. So yeah, very, very happy with that lens, very happy with the risk profile in terms of the glare. The hard part with the light adjustable lens is really the post-operative care a patient has to do on their own. We do those adjustments by using a light that will reprogram the lens. It's actually using a UV light. We don't want any adjustment to that lens to happen outside of those treatments. And so the patients who are having that lens have to wear these kind of special UV protecting glasses through the adjustment process. And they don't look too bad. They're a little bit Clark Kenty, but they're just a little bit of dark frame, and they could be either a kind of a sunglass or a clear lens that they come with, and those are provided with the lens. And patients would need to wear those while they are awake until they complete the adjustment process. They also have a couple additional extra visits where they need to come in and have those adjustments done. Those can only be done in clinic. So while it's very accurate, it's less ideal for patients who are coming out of town. I know I have some patients who fly in from out of town, and that's a hard lens to do for someone who's coming in from out of town, but certainly doable. But very, very pleased with the outcomes with that lens.
Sounds very futuristic. So obviously, great technology that's being developed in the field of ophthalmology. Another question came in, Dr. Barrett, regarding you mentioned during the presentation the word touch up. When are touch ups needed, and what's the impact of outcomes, and how do you use touch ups to help outcomes?
A really good question. So, and again, as I speak about this, I may use two terms interchangeably, either touch up or enhancement. Both are referring to the same thing. And typically, this comes into play with what some of the laser vision correction procedures, LASIK and PRK. So, say you have your LASIK at age 25, and it's been good for the last 10, 15 years, but now you're finding that the vision is getting more blurry at distance again. And some patients will say, my LASIK is wearing off. It's not wearing off. It's just maybe the lens in your eye is starting to change a little bit, or your eyes change shape a little bit, and you're finding that glasses are helpful again. We can then, if again, we'd have to screen and make sure that the cornea is thick enough and appropriately shaped and the prescription's been stable. But we can then do PRK to touch up or enhance the vision again, to again treat that prescription to give the good distance vision. We can also do this after refractive lens exchange. Say maybe we use one of those advanced technology lenses that has extended to the focus far and up close at the same time. And maybe there's a little bit of prescription still present, after surgery, something we didn't anticipate, but we see there's a little bit there. We can do an enhancement or touch up with that. And if we're doing that after, for example, a refractive lens exchange with one of these advanced technology lenses, that's something that's actually included in our service. If someone finds after LASIK or PRK in the first 12 months, even that things aren't quite where they expect to be, that's very uncommon, but we know that's possible. We see that in less than 1 or 2% of the time. In the first 12 months, we would do that touch up or enhancement again is a free or included procedure as part of that initial treatment.
Dr. Barrett, the last question, and then we'll let you go. We very much appreciate your time today, and I think this has been an excellent program. The last question before we go is how do I determine, or how do you help me determine which procedure is best for my vision?
Usually it's a conversation. Just like I mentioned before, there is no one cookie cutter, this is best for everybody approach. Part of it depends on the shape of your eye and the health of your eye. Part of it depends on your age. Part of it depends on what your goals are as well. So there needs to be both an exam, but also a discussion to determine what are you wanting, what is your goal, and then determining which procedure would best help you achieve that goal or best be in alignment. And it might be that you have three goals, multiple levels of goals, and maybe there's not a procedure that can accommodate all of those goals, but maybe we can accomplish the first two. And so there may be a bit of a compromise there, but just being realistic and upfront and honest with us about what your goals are, and we'll be realistic and honest back as far as what we would expect to help you out and what would be realistic. But I think knowing as you come in, number one, what is important to me as a patient? I really want my distance vision. Or maybe I really find that I can't stand I'm looking for glasses all the time around the house. I have 20 pairs of readers. I don't want to have 20 pairs of readers. I want something that does far and near. Or maybe someone's a trail runner or a bird watcher, and to them, far away is everything. And so just knowing what your goals are as you come in and letting us know that really gives us the best chance of helping you achieve your goals. And then we would do our testing, looking at the shape of the cornea, the shape of your eye, the health of your eye, the status of your lens. Is it clear? Is it starting to become cloudy? All of that would help us determine, knowing your goals, knowing the health of your eye, what procedure would help you achieve the best chance of being thrilled with your vision afterwards.
Well, I think all these procedures you've talked about today are life-changing possibilities for a number of patients out there. So, kind of with that said, I would again like to thank you so much for the presentation today and answering all these questions about LASIK, PRK, ICLs, RLEs, all these acronyms that we use in the field of ophthalmology. I'd like to remind everybody that probably the best way you can see on your screen today to find out if you're a candidate is either through the virtual screening, to book a consultation, or if you just want to speak to somebody in the office about what you heard today and you have additional questions that we didn't get to or you thought of after the presentation, please feel free to call us. And Dr. Barrett, again, thanks so much for your time. I think this has been an excellent presentation today, and we just want to say thank you to all the people that participated today. So with that said, I'll bid everyone a good day. Farewell. We'll look forward to seeing you at the Hollingshead Barrett Eye Center for a vision correction consultation or a screening. Thank you very much.
Thank you everyone for joining us today. Appreciate it. Thank you.